Good evening and welcome. I'm Jean Johnson, one of the librarians at Stanford Healthcare at Stanford Library. Thank you for joining us at tonight's talk, Living Better with Atrial Fibrillation. It is my pleasure to introduce our speaker, Rahul Sharma. Dr. Sharma is an interventional cardiologist with specialized clinical and research interests in structural heart disease, particularly transcatheter valve therapy. He is Director of Structural Interventions at Stanford Healthcare and Associate Director of the Cardiac Catheterization Laboratory and Clinical Associate Professor of Medicine at Stanford School of Medicine. Throughout the program, please enter any questions in the Q&A box at the bottom of your screen. And at the end of the talk, Dr. Sharma will answer as many of these as possible. Doctor, I'll turn it over to you.
Thank you, Jean, and thank you for the invitation to speak. It's a pleasure to be here, and just to reiterate, as Jean mentioned, please feel free to ask questions throughout the talk. Hopefully, through this next 30 or so minutes, I'll be able to answer a lot of those questions through the content, but certainly if there are any specific questions, please feel free to ask them and we'll address them in the time remaining after the talk. So these are my disclosures. I do receive grant support and consulting fees from some of the companies. And just important to note that the products, services, or therapies in this presentation I'm discussing may be subject to some regulatory approval or clearance, and therefore the labeling of the use of these devices may change. And the opinions that are given throughout this presentation are certainly my own personal professional opinion and don't reflect the opinions of others. So what will we cover in this evening? I'm going to cover a few topics. Firstly, level setting in terms of how does the heart work? What is its primary function, and particularly as it relates to regulating the rhythm of the heart. Once we've established that, trying to understand what exactly is atrial fibrillation, and importantly, what the connection is between atrial fibrillation and the risk of stroke. We all know that stroke is a very catastrophic clinical outcome, but why is atrial fibrillation linked with an increased risk of stroke? And what does this mean for you if you're a patient or has a family member that suffers from atrial fibrillation? We're going to spend a bit of time focusing on the treatment options for patients who have atrial fibrillation, particularly as it relates to reducing both the risk of stroke, but also the risk of bleeding that can often be associated with taking blood thinners, which are designed to reduce the risk of stroke. And then we'll talk about some of the resources that may be available to you to get further information, including, of course, being able to come and see me and my team at Stanford. So I'm going to present these contact details at the end as well, but for those who I know might have further questions, who'd like to make an appointment to come and see us, or simply get more information, this is my clinic's telephone and fax number. We have an email address that's answered by my clinic nurses and myself, and then most importantly, a website which contains all of the pertinent information about everything I'm discussing here today, as well as the latest and greatest in technologies and clinical trials. So let's get started with how the heart works. The heart is divided into 4 chambers. There are 2 upper chambers known as the atria, and that's where the term atrial fibrillation comes from, relating to fibrillation of the atria. Most commonly, the left atrium is the site of the majority of atrial fibrillation, and then the ventricles, which are the 2 larger lower chambers. The upper chambers and the lower chambers are divided by valves, which regulate the flow of blood through these. And this is important because one of the contributors to atrial fibrillation and development of atrial fibrillation is, in fact, valvular heart disease. So there are a lot of patients who may have diseases of one or more of these valves, which contributes to and might exacerbate their underlying atrial fibrillation. Conversely, there are some situations in which atrial fibrillation itself can lead to enlargement of the left atrium and stretch the valve on the left side of the heart called the mitral valve, which then creates a leak of the mitral valve. So there's an interplay between the different chambers and valves of the heart. The purpose of the heart is, of course, to pump and circulate blood to the rest of the body. So the left side of the heart receives blood that's rich in oxygen that's being breathed in through your lungs, and then pumps that through that left chamber via the aorta out to the various organs of the body, supplying them with oxygen-rich blood. When the different organs and tissues of the body have extracted oxygen, it returns the blood which is now lower in oxygen content via the venous system of the heart to the right side of the body, and the right side of the heart, sorry. And then the right side of the heart will pump that blood back to the lungs where it gets reoxygenated, and so the cycle continues. So what exactly is atrial fibrillation? Atrial fibrillation, or AFib, or AF as it may be commonly known, is a heart condition that causes the upper chambers, the atria of your heart, to beat in a very rapid and chaotic rhythm. Often this is diagnosed on an EKG to confirm that in fact the rhythm is atrial fibrillation. But a lot of times patients may experience or be told that they had a fast and irregular heartbeat. The classic description of atrial fibrillation is that it is irregularly irregular. A normal heartbeat is between 60 to 90 beats per minute and is very regular, whereas atrial fibrillation is quite often faster than this and has a very irregular cadence. It's thought that the origin of most atrial fibrillation is from this left upper chamber or the left atrium, where there's a series of abnormal electrical impulses that originate and propagate throughout the heart, causing this abnormal rhythm. So atrial fibrillation, for those that suffer from this, is not a rare disease. In fact, it's quite prevalent, and it's a very common abnormal rhythm or arrhythmia of the heart, and is indeed a growing problem. You look at this graph, there's an estimate that approximately 5 million people in the United States alone were diagnosed with atrial fibrillation in 2020. That number is expected to increase exponentially to over 10 million and closer to 12 million by the year 2030. Of course, atrial fibrillation has a significant impact on the quality of life, and in some instances can also affect quantity of life and be a cause of death. Fortunately, there are a number of treatment options to address not just the rhythm itself, but the risks that come with the abnormal rhythm, particularly that of stroke. Unfortunately, there are many risk factors for the development of atrial fibrillation, and one of those is advancing age, which is of course something that we can't control and is inevitable for all of us. And that's part of why atrial fibrillation continues to be a growing problem in our aging population. So there are a number of subtypes of atrial fibrillation, and if you've been diagnosed by a physician, either a primary care doctor or a cardiologist, or a subspecialized cardiologist known as an electrophysiologist, which is a type of cardiologist that specializes in electrical abnormalities of the heart, such as atrial fibrillation, they may have used terms such as paroxysmal, persistent, or permanent. And these are the different types of atrial fibrillation. And these have an important relevance in terms of the appropriate treatments that may be available to you depending on the type of atrial fibrillation that you have. So the first type of atrial fibrillation is paroxysmal. And what this means is that the abnormal rhythm can come and go. And most importantly, it usually can stop on its own. This can happen in the setting of an acute illness. It can happen when the electrolytes in your body are out of balance. It can happen during a stressful situation. More often than not, this is self-limiting and is generally simpler to treat. Persistent atrial fibrillation is a little bit more serious. It usually lasts less than a week, but can become permanent, and more often than not requires some sort of intervention in order to return you back to a normal rhythm. And then permanent atrial fibrillation is perhaps the one that we want the least if you're going to have atrial fibrillation, and that is where the heart rhythm cannot be restored back to a normal rhythm, despite trying with either something called a cardioversion, which is an electrical shock in an attempt to restart the heart back to a normal rhythm. It may not be able to be restored using medications that are designed to restore normal rhythm, and it may not even be able to be restored using a procedure called an ablation, where an electrophysiologist goes in and does a procedure to try and burn the areas that are responsible for the atrial fibrillation. So patients with permanent atrial fibrillation, unfortunately, despite any attempts to revert you to normal rhythm, remain in atrial fibrillation. So what causes atrial fibrillation? As I mentioned, it's a disease of aging in addition to other risk factors. So as you grow older, the risk of AFib increases, especially after the age of 60, where it starts to increase quite rapidly with each additional 5 to 10 years of age. There are a number of factors that play into your risk of atrial fibrillation aside from age. High blood pressure or hypertension is one, and for many reasons, it's important to tightly control your blood pressure, whether that's with medications or lifestyle or a combination of both. I mentioned earlier there may be underlying abnormalities in the heart, such as those that affect the valves, which may contribute to the risk of atrial fibrillation. And so often it's important to correct those underlying abnormalities, such as leaking of the valve or a severe narrowing of a particular valve, in order to reduce the risk of either continuing or permanent atrial fibrillation or recurrence of atrial fibrillation if it is indeed paroxysmal or persistent. Extensive sports in some instances have been shown to increase the risk of atrial fibrillation. There are, of course, genetic factors that may be linked to developing atrial fibrillation. There's also some association between alcohol consumption, particularly at high amounts, and developing atrial fibrillation. And then sometimes there's no clear factor identified in why patients may develop atrial fibrillation. So what are some of the signs and symptoms that you may experience if you have atrial fibrillation? Some of these can be very specific and some of them can be very generic. A lot of patients who have atrial fibrillation have what's called silent atrial fibrillation, where they don't have any noticeable symptoms at all. But those patients that do experience symptoms may experience one or more of shortness of breath, particularly with exertion. Sometimes while a patient is sitting and not doing much, in spite of having atrial fibrillation, the demands on the heart and on the body are limited, and so they may not experience symptoms. But once they get up and start to walk around or exert themselves, they may start to develop shortness of breath. They may feel that their heart is racing or fluttering, or they may experience palpitations. And this may reflect the underlying irregular fast heart rate that is often associated with atrial fibrillation. Sometimes the symptoms can be as vague as fatigue, just a general sense of tiredness or having less energy than previously. And then in rarer circumstances, patients may experience dizziness or lightheadedness, again, when they're exerting themselves and performing physical activity. Some patients may have one of these symptoms, some patients may have all of these symptoms, and as mentioned, some patients may have none of these symptoms, where atrial fibrillation is picked up incidentally when someone checked their pulse rate or someone did an EKG. So how does atrial fibrillation tie into stroke, and why is this important? We know that patients who have atrial fibrillation may be at greater risk for stroke than people with normal heart rhythms. In fact, when we look at large populations, we found that atrial fibrillation actually increases your risk of stroke by 5 times compared to the same person that does not have atrial fibrillation. And when we think about the risk factors that go into stroke in patients who have atrial fibrillation, they include factors such as congestive heart failure, high blood pressure, advanced age, diabetes, your gender or sex, and the presence of any vascular disease or disease of the arteries in your heart, your brain, and other areas of your body. Unfortunately, atrial fibrillation can put you at risk for other complications. So blood clots can form, and that's because that irregular heart rhythm can cause blood to pool and form clots in an area of your heart called the left atrial appendage. And that's very important later because we'll talk about one of the therapies, which is closure or occlusion of that left atrial appendage, which is like a little pouch. When the heart's beating in a regular rhythm, it's squeezing all of that blood around and it's moving through. So the blood that sits in the heart doesn't really have time to sit there long enough for clots to form. When you have atrial fibrillation, the heart is not beating in a regular coordinated fashion. And what that means is that blood has time to pool and coagulate and thicken, and clots can form. And of course, those clots, if it forms in the left atrial appendage and manage to escape that pouch and travel through the heart and to the brain, can cause a stroke, which can of course be catastrophic. In addition, left untreated for long periods of time, particularly if the atrial fibrillation is running quite fast, the decreased efficiency of the heart can eventually lead to heart failure. So as mentioned, the risks include blood clots, stroke, and heart failure. And this is just a picture depicting how that occurs. So on the left there, you have normal coordinated electrical activity of the heart. The electrical activity starts in one region here on the right side, and the coordinated fashion spreads throughout the heart, causing different parts of the heart muscle to contract at the appropriate times. And that's what a normal coordinated heartbeat looks like. In atrial fibrillation, you've got all of these random sporadic impulses creating a uncoordinated contraction of the heart. And what that leads to is, instead of the heart squeezing, this blood forms in this left atrial appendage, which is this pouch off to the side of the left atrium, which is the site of clot formation, which may go to the brain. And so sometimes, as I mentioned, the blood will pool in the left atrial appendage. That stagnant blood then becomes an ideal environment for a blood clot to form. If you're not on blood thinners, that clot can form very quickly. The blood clot then can dislodge from that left atrial appendage and travels through the arterial system on the left side of the heart into the arteries that lead to the brain. And if it does go up to the brain, it can lodge in the vessels of the brain, restricting blood flow and the delivery of oxygen to the brain tissue, therefore causing a stroke. Unfortunately, the risk of this happening is quite high, and it's estimated that approximately 1 in 3 or 33% of patients who have atrial fibrillation will have a stroke in their lifetime. More than 90% of the clots that cause stroke are thought to come from that little pouch called the left atrial appendage, which is why that is a target for potential closure to try and minimize that risk of stroke. We know that strokes that occur in AFib are more frequently fatal and disabling than strokes that may occur for other reasons. It's important to recognize the signs and symptoms of a stroke, and the be fast mnemonic, which has been quite popular and hopefully that you're all aware of, are things to look for to suspect if someone's having a stroke. So the B stands for balance. So if the patient experiences a sudden loss of balance, a sudden unexpected headache or dizziness. E for eyes, if there is sudden blurring of the vision. F for face, where one side of their face appears to be drooping. A for arms, where they experience sudden onset arm or leg weakness. S for speech, where there is difficulty in speech, where there was no difficulty prior. And then perhaps the most important, the T for time. And that's the importance of quickly getting help, calling an ambulance, calling 911 to get healthcare assistance immediately. Because the faster you get someone who's having a stroke to a hospital and the faster they're treated, the better their outcomes in terms of restoring brain function, but also in terms of survival. So be fast is a very important mnemonic to know and understand. So what are the treatment options for patients who have atrial fibrillation? So the way we think about it is once a patient has been diagnosed with atrial fibrillation, there are 2 priorities for us as healthcare practitioners. The first, and arguably the more important, is to reduce their risk of stroke. We've talked about how strokes can occur when blood pools in that left atrial appendage, clots form, and those clots can travel to the brain. And so the way we try and reduce the risk of stroke is either through oral anticoagulation medications or blood thinners, and we'll talk about the specific blood thinners shortly, or left atrial appendage closure, which is a relatively new procedure, which is quite helpful in patients that are unable to tolerate blood thinners. The second priority in treating patients with atrial fibrillation is actually to manage the underlying abnormal rhythm. You have to remember that that underlying irregular fast heart rate is the cause of the stroke and other associated issues. And so we need to try and figure out if we can actually treat those. So the patients who had paroxysmal or persistent atrial fibrillation, we're trying to avoid them developing permanent atrial fibrillation. There are medications that can be prescribed to either try and control the rhythm and restore a normal rhythm, or in patients in whom it's difficult or impossible to control their rhythm, where we accept that the atrial fibrillation is going to be permanent, then it's important to control their rate to make sure that the heart's not beating excessively fast in an inefficient way, which may eventually lead to heart failure. So you may be on a combination or one of a rate controlling medication and or a rhythm controlling medication from your primary care doctor or your cardiologist. There are also procedures that are designed to eliminate the atrial fibrillation. You may recall that in atrial fibrillation, in that prior diagram, the origin of those abnormal electrical impulses occur from that left atrial area. Specialists called electrophysiologists can go in through a catheter-based procedure in the vein in the leg and go up to the heart and try and zap or burn the areas that are thought to be originating the atrial fibrillation in the hope that they can eliminate that. And then, of course, there are some lifestyle changes. For example, if you're drinking an excessive amount of alcohol, reducing that intake to a more moderate intake may help in managing atrial fibrillation as well. So we're trying to address it from a number of different perspectives. One, to manage the underlying abnormal rhythm of atrial fibrillation, be it with medications for rate or rhythm control, or procedures to be a bit more aggressive and actually try and completely get rid of the atrial fibrillation on a background of lifestyle changes, while deciding how to reduce the risk of stroke. either with medications to thin the blood or a procedure called a left atrial appendage closure. These are just going into details. The rate control, this is, as I said, to make sure the heart's not beating too quickly. The rhythm control to try and restore back to a normal rhythm and importantly, keep it there. It's important to remember that the risk of recurrence of atrial fibrillation is important. Just because you've had it once and it goes away doesn't mean it's gone away forever. Depending on why you developed atrial fibrillation, your age, and your other risk factors, you have an increased risk of having atrial fibrillation again. So it's very important, depending on the situation, to try and not just get you back to a normal rhythm, but try and keep you there. I mentioned lifestyle changes such as regular exercise, a healthy, balanced diet, avoidance of smoking, and regulating alcohol and caffeine intake are also important. Those are also important for a host of other cardiovascular issues, but also particularly for atrial fibrillation. And then, as I mentioned, a cardioversion procedure, which is a delivery of an electrical shock in an outpatient setting to try and restore normal rhythm, or the ablation procedure, where you go in and try and burn the area to restore normal rhythm. So reducing the risk of stroke, as we mentioned, blood thinners or anticoagulation medication and left atrial appendage closures are both different ways to try and protect you from a stroke or the related complications from blood clots. Blood thinners, which are commonly used, are designed to reduce those risks of blood clots, and they're divided into two groups. Antiplatelet medications like aspirin, which a lot of people are on, and then probably more applicable to atrial fibrillation, anti-clotting or blood thinning medications such as warfarin or Coumadin, which are important to help clots, prevent clots from forming in your blood and causing a stroke. Now, these are some of the common blood thinners that patients may be on. Warfarin, I mentioned, Eliquis, Redaxa, Xarelto, and others. A lot of patients can take blood thinners for years without serious side effects, and they have no issues whatsoever. But unfortunately, by virtue of the way that the blood thinners are protecting, they are thinning the blood. They help prevent clots, but they also, at the same time, increase the risk of bleeding. And that may be an issue for a lot of patients. And so when you're talking to your managing provider, whether it's your primary care doctor or your cardiologist, it's important to consider your treatment options. And it's important to have a conversation about weighing your risk of a stroke against the risk of a serious bleeding problem. As you can imagine, you could be on a blood thinner, but let's say you have a risk of falls and you fall regularly and you hit your head. If you're on a blood thinner and you have a bleed into your brain, that could be quite significant and potentially catastrophic. So it's very important to try and balance those risks, and that's through a conversation with your provider. And that's really where this idea of left atrial appendage closure comes into play. Closing the left atrial appendage, which you'll recall is that little outpouching from the left atrium, where the majority of clots that cause stroke in the setting of atrial fib form, is an effective way to try and reduce stroke risk in people who have AFib, not caused by other problems like heart valve problems. A left atrial appendage closure implant, it's a permanent implant, and it's designed to close off that little pouch or the left atrial appendage so that blood clots can't form there. And even if they do, they can't escape into the arterial circulation and go to the brain to cause a stroke. And this is important because it allows you to prevent the risk of stroke, but also allows you to be off a blood thinner, therefore protecting you from the risks of bleeding. The implant itself is a one-time procedure. It's a minimally invasive procedure that may reduce both your stroke risk and bleeding risk for the lifetime that that device is inside. It's a very effective stroke risk alternative to blood thinners, particularly if you have a high risk of bleeding. The implants reduce the stroke risk without the worries that come with a lifetime of blood thinners. And currently, there are two commercially approved, FDA-approved devices. One is called the Watchman device, and the other, somewhat newer, called the Amulet left atrial appendage closure device. And they're both commercially available options. As I mentioned, the procedure is safe and minimally invasive. Importantly, it is not an open heart surgery procedure, and you cannot see the device outside the body. The procedure is typically done under general anesthesia. However, I will say that in my practice, I actually do this under what's called conscious sedation, where the patient is awake and does not require to be under general sedation, general anesthesia. And that's important because the risk of general anesthesia is greater than conscious sedation, and the recovery is a bit slower. So for me, it's important to minimize the risk for a patient and also allow them to recover faster. I do this under local anesthesia. Procedures typically take less than an hour. I think my average procedure time is about 30 minutes. And in my practice, patients don't stay overnight unless there's a particular reason. They all go home the same day. So overall, it's a very minimally invasive low impact procedure, but with significant upside. This is an example video of the procedure itself. Basically, as I mentioned, the patient is brought in and placed under sedation. We get access in the vein in the leg through a tube called a sheath, and then feed a narrow tube over a wire from the leg up to the heart. We enter the right side of the heart, and then using a special catheter, we puncture a very small, tiny hole with a needle to go to the left side of the heart, which is where the left atrial appendage is located. We place a very gentle atraumatic wire into the left atrial appendage, and then we place a tube inside. We take pictures of the appendage, and you can see that little pouch there is the appendage, to try and identify the different shapes and sizes in order to determine what the best device is to go in there and seal it. Once we've determined which size and type of device we want, through the tube that's placed there, we take a picture just to see what we're dealing with. We inject a small amount of contrast dye into there, usually less than 5 or 10 cc's. And then through the tube, and in this case, this is an example of a Watchman device. We're implanting this device carefully and slowly into the appendage and sealing it off. If we don't like the position, we can make a minor adjustment, as you're seeing here in the video, place it either deeper or more shallow. In this case, we're going a little bit deeper. And then we're making sure that we're effectively sealing off that left atrial appendage so that any clots that form behind the device are trapped there forever. Eventually, over time, the tissue of this device will grow into the heart tissue and become one with the left atrial wall. And the idea is that once that ingrowth occurs, you've now got an effective barrier between the circulation of the body and this pouch where most of these clots form. That was the Watchman device. I mentioned there are 2 commercially available devices. In addition to the Watchman device, the second device that's available is called the Amulet device. It's a little bit different. You can see here, instead of being one device, it's actually got 2 components. There is a lobe that sits in this pouch called the appendage, and then there's a disc which sits on top of it. So there's 2 layers of sealing of that can occur. I use both the devices. Depending on each patient's individualized anatomy, I select the device that I think is going to be better suited to the patient so that we ultimately end up with an ideal result where we've completely sealed off that appendage, because that's the goal. So how do you know if a left atrial appendage closure is going to be right for you? First of all, you of course have to have atrial fibrillation, and that has to be atrial fibrillation that's not caused by heart valve problems, because patients who have heart valve problems and atrial fibrillation are a slightly different group, and they may not derive the same benefit from these procedures as patients who have atrial fibrillation unrelated to their valve function. In addition, you need to have experienced either bleeding or be at high risk of bleeding when taking blood thinners. And that may be a lifestyle, as I said, where, for example, you could be outdoors a lot, riding a bike a lot, where there's a risk that you fall off and therefore you could bleed. You have a particular job that exposes you to trauma and therefore bleeding is just a big no-no, or a particular health condition that puts you at risk for bleeding. You may be on multiple other medications that act as blood thinners, and so the interaction between all of these or other medications may also be an issue. So if any of these problems arise, you may be a candidate to have a left atrial appendage closure and get off your blood thinners. A lot of patients ask about cost. It's important to know that the left atrial appendage closure is covered for eligible Medicare patients who meet certain appropriate criteria. And now it's also covered by an increasing number of commercial users. And that's a conversation that we can have with your referring provider to make sure that there is no significant out-of-pocket expense incurred. It's important to remember that while blood thinners have to be taken every day for the rest of your life and represent an ongoing cost, the left atrial implant is really a one-time procedure and a one-time cost. And so in certain instances, it can actually save the patient money over time. And we're seeing that as an increasingly prevalent reason where patients are coming to us to have this procedure done. So I'm going to stop there and open the floor to questions. Again, I wanted to show the contact details. I'm sure a lot of patients out there are thinking, I need to go and see a physician about this, or I want a second opinion. And so this is our telephone number of the clinic, our fax, if you want to keep that for your referring provider to send us a referral. As I mentioned, you can send us an email. And then of course, there's our website, which has a lot of information about not just this in terms of this procedure or this condition, but also a whole host of other conditions and potential treatments that we offer at Stanford.
Well, thank you, Dr. Sharma. That was really fascinating. I've got a few questions here, as you know. There are a couple of questions about what if you're not feeling any symptoms? You've been diagnosed with AFib, but you don't have any symptoms. What happens then? Do you need an intervention?
Yeah, so I think if you don't have symptoms or you have what's called silent atrial fibrillation, in some regards that's good because you're not having to treat the symptoms. You're not feeling unwell as a result of it. There's no limitation in terms of what you can do. Unfortunately, though, the risks associated with atrial fibrillation, regardless of whether you have symptoms or not, are still very much the same, particularly as it pertains to the stroke risk. So whether you feel it or not and have symptoms or not, if you have none of the shortness of breath, none of the fatigue, none of the dizziness, none of the irregular fast beating heart rate, unfortunately, regardless, you're still exposed to that risk of stroke that comes with AFib or atrial fibrillation. So it's still important to have that conversation about the priorities of either rate control, rhythm control, but also protection against stroke risk, whether it's with a blood thinner or the left atrial appendage closure device.
Okay, thank you. It seems that AFib is more common in men than women. Is that true?
It is true. AFib is more common in men than women, but unfortunately, women who have AFib tend to have worse outcomes than men, particularly in terms of stroke risk. And so when we look at the risk factors for developing a stroke if you have AFib, being a woman is actually higher risk than being a man. But you're right, the chance of developing AFib is higher in men than women. But once you have AFib, unfortunately, women have a slightly higher rate of adverse events.
Okay. What is the impact of a strong family history of AFib?
There is certainly a genetic component to the development of atrial fibrillation. So I think patients who have a long-standing family history and no other risk factors, it may be attributable to genetic factors, but that's just one of the many factors that contributes to the development of atrial fibrillation, particularly, as I mentioned, as we've got an aging population.
And the follow-up question for that one is, what tests are available to determine if you have AFib?
So I think it starts off with a clinical examination where either by feeling your pulse or listening to your heart, there's a suspicion that there's an abnormal irregular heartbeat. But the real diagnosis has to be made with an EKG, either a 12-lead EKG or a monitoring device that is capturing your heart rhythm beyond just an instantaneous period for a period of time. So sometimes a patient will get an EKG in their doctor's office, and that's how it's diagnosed most commonly. Sometimes their Apple Watch may tell them they have an irregular rhythm, and then that needs to be confirmed with an EKG. And then sometimes patients might experience irregular rhythms, but at the time they have an EKG, it looks completely normal. But when they go away and have a longer-term monitor, like a Zio patch or a Holter monitor, which they wear for, say, 2 weeks, that's when it's detected over a longer period of time, especially if they have that paroxysmal type of atrial fibrillation that can come and go at any time.
Are there any studies that show ablation is better than taking anti-arrhythmic medications for the long term?
Yeah, I would say that the treatment therapies, which include both medications and ablations, have varying degrees of success, and it's very individualized to the patient. Generally speaking, the first step is to start with the medications, what's called anti-arrhythmic medications. And if they fail or the patient can't tolerate them, then the next step is usually ablation. In some instances, going straight to an ablation may be appropriate, but again, that's a discussion to be had with the specialist like an electrophysiologist to talk about what medications have been tried, at what dose, have any underlying other factors that are reversible being corrected, and then if those have been met, consider an ablation procedure. It's important to also know that an ablation procedure is not a guaranteed. Sometimes one procedure is adequate, but sometimes patients may require multiple ablation procedures to target the atrial fibrillation. And unfortunately, there are some patients who, despite many ablations, still have atrial fibrillation.
Okay, thank you. There were several questions about how many can one have for ablations.
I mean, there are some patients who will have 3 or more, but at that stage, it's it's really diminishing returns, and the chances of a successful ablation really do start to go down once you've had that many.
I'm not sure. We've got a question about the risks of these interventional procedures. Can you talk about that?
Absolutely. So it's always important, in a discussion I'll always have with patients when considering any procedure, or for that matter, any therapy, even medications, to weigh up the risks versus the benefits. And so with these procedures, there are risks. There are risks of bleeding and infection where we go in the vein in the leg. The risk of that being significant is usually less than 1% to 2%. There's a risk when we go up to the heart that we inadvertently cause a hole in the heart. Again, the risk of that is extremely rare, particularly in experienced hands. We're talking a risk of less than 1 in 500. There's a risk that when we put, for example, the device into the left atrial appendage, you can develop a leak around it. That risk is usually less than a few percent. Sometimes clot can develop on the device itself. Again, that risk is, I would say, less than 3 or 4%. The risk of something really catastrophic happening where you would require emergency open heart surgery, I would quote patients in the order of 1 in 1,000. So there are risks, but the rate of those risks is extremely low. And when you look at the chance of success against the benefit of these procedures, clearly there's a significant benefit to risk ratio overall.
Okay, great. Another question is, will COVID-19 cause AFib into seniors?
It can do. Any infection can precipitate atrial fibrillation. So certainly even, an active infection with COVID may be a precipitant for atrial fibrillation.
Is there any clinical significant connections between the onset of AFib after having arterial stents put in?
Sometimes atrial fibrillation can occur following a procedure in the heart. It can cause another procedure that was unrelated, may cause irritation of the heart, and that may precipitate atrial fibrillation. That is a known entity. It can happen in roughly 5% of patients undergoing a cardiac procedure. Fortunately, more often than not, that's the paroxysmal type of atrial fibrillation, which is often short-lived and self-limiting. But in rare instances, that can progress and will need to be addressed. But again, even if it's short-lived or a little bit longer, that stroke risk is still very much real and needs to be addressed.
How does the LAA or LACC procedure relate to ablation?
So they're very different. The left atrial appendage closure, or LAACC, is designed to block off the appendage and prevent stroke risk, allowing you to get off your blood thinner and reduce bleeding risk. So it's really about the stroke-bleeding balance. The ablation is designed at targeting the underlying problem, which is the rhythm itself. It's designed to try and restore normal rhythm. So both of them are targeting the atrial fibrillation in different ways, but one is actually targeting the abnormal rhythm, that's the ablation, and the other, the left atrial appendage closure, is actually targeting the risk of having atrial fibrillation as it relates to stroke and bleeding.
So would it be possible that you would try one ablation before the LACC?
Absolutely. And so one of the things that I do in my practice is I work very closely with my electrophysiology colleague, Dr. Alex Perino. And so we often see patients together to target from both sides. So he will look at a patient as it relates to the medication that they're on to control their atrial fibrillation, to consider ablation, and then where appropriate, I'll provide potential left atrial appendage closure in the same patients. So it's very much a holistic approach to looking at atrial fibrillation.
Let's see, we've got some very specific ones. With mitral valve and tricuspid surgeries, is it common practice to fix the left atrial appendage?
Sorry, Jean, could you ask that again?
It says, with mitral valve and tricuspid surgeries, is it common practice to fix the left atrial appendage, I guess, while having the surgery?
So depending on the surgeon, there are some surgeons who, when they're doing any sort of cardiac surgery, because they're already in there, will tie off or ligate the left atrial appendage so that it doesn't become an issue in the future, even if you don't have atrial fibrillation at that point. based on the premise that you may develop atrial fibrillation in the future, and it takes that out of the question, at least in terms of the stroke risk.
Right.
Although it's important to remember that the left atrial appendage is not the only source of stroke, but more commonly, a lot of surgeons will only take care of the left atrial appendage if the patient has atrial fibrillation at the same time as taking care of a mitral or tricuspid valve. In addition to tying off or removing the atrial appendage, they can also perform their version of ablation from the inside surgically as well.
You mentioned 1/3 of AFib patients get stroke. Is that before or after they may have started taking blood thinning?
That's in the absence of taking any blood thinners. The role of the blood thinners is to reduce that risk.
Does paroxysmal AFib ever disappear for good?
Yes, by definition, that is paroxysmal atrial fibrillation. It should go away. If it lasts beyond a week and keeps coming and going, one would argue that it might be persistent, but paroxysmal atrial fibrillation should be self-limiting.
How do you determine if AFib is caused by a heart valve problem or defect?
So once atrial fibrillation is diagnosed, let's say on an EKG, the next step is to look for underlying reversible reasons why it may be, including a full examination, blood tests, and also an echocardiogram or an ultrasound of the heart. And that's going to look at the heart function in terms of the way the heart's pumping, but also the valve function to make sure there's no underlying valvular cause of the atrial fibrillation.
This person says they've had the TAVR procedure. Does that prohibit having the LACC?
No,
procedure?
not at all. I do a lot of TAVRs, and a lot of the patients have the same risk factors, including atrial fibrillation. And so there's a significant crossover between the population of patients in whom I place valves, whether it's a TAVR, which is a transcatheter aortic valve replacement, or a mitral or a tricuspid procedure via catheter, that I will then also at a different date do a left atrial appendage closure, or vice versa. I've had patients in whom I placed a left atrial appendage closure, and down the track they develop other problems that require other catheter-based solutions. So it does not prohibit additional procedures.
Great. I've had a couple questions about pacemakers and these interventions. What is the relationship if one has a pacemaker installed?
So if you have a pacemaker, the left atrial appendage occlusion does not eliminate the need for it. The need for a pacemaker is usually to regulate a heart rate or heart rhythm. Usually a slow heart rate requires a pacemaker, or a rhythm where there's a lack of coordination between the left and the right side of the heart to try and bring some synchrony back into that. And in some cases, a defibrillator, which is a different type of pacemaker designed to restart the heart should it stop. That's a separate issue that requires a pacemaker to that which we're trying to prevent with the left atrial appendage closure, which is, again, to manage the risk of stroke versus bleeding. Now, in certain instances, when ablations occur, sometimes the ablation either inadvertently or deliberately is very aggressive, and there is damage to the internal pacemaker of the heart, which necessitates the need to have a permanent pacemaker implanted. But that's a rarer, more unusual situation. To simplify it, there's not really a clear correlation between the two.
Okay. What steps should be tried before an ablation?
So the first step is to try and correct any reversible underlying factors, whether they're lifestyle issues such as losing weight, treating obstructive sleep apnea with a CPAP machine, making sure you don't have any deficiency of your electrolytes. If you had an infection, a short-lived chest infection, treating that, getting over that, there may be no need to do anything further than that. If, despite correcting any underlying factors, or there are no correctable underlying factors, there's still atrial fibrillation, medications, A, to manage stroke risk, whether it's the blood thinners, and then B, to decide whether you're going to take an approach to control the heart rate or to try and restore rhythm with medications. Those are the things to be tried first before considering an ablation. The other thing to consider is the procedure called a cardioversion, where a shock is delivered to try and reset the rhythm back to normal. All of those are generally tried before an ablation is attempted as a first line.
I have a question here about a maze procedure. Is that part of anything related to this?
A maze procedure is a surgical approach to ablation. And so the surgeons may perform the maze either as part of an additional cardiac surgical procedure, or more recently, there's been what's called a hybrid approach where their electrophysiologist performs an ablation through a catheter, and then the surgeon performs the ablation through small surgical ports in the chest. And that's called a hybrid maze ablation procedure.
Are there any age limitations for any of these procedures?
No, I think one of the issues is that this is a disease of advancing age. And so a lot of our patients are in fact elderly. That's a good reason why they're not on blood thinners, because they're older and they're frail. And so their risk of bleeding is high. So there is no specific age cutoff. I've certainly treated patients who are above 100. It depends on the functional age of the patient. Obviously, we don't want to be doing procedures in inappropriate patients. So for example, if a patient is bedbound at a nursing home and not doing a lot, not very functional, that's not going to be an appropriate patient in spite of their age. Conversely, there are some very spry, very active patients in their 90s in whom we absolutely will consider all of these procedures.
Great. The next question, in case of silent paroxysmal AFib, is there any test long enough to determine whether it is no longer continuing?
It's a great question. So I think I mentioned that the EKG is just a snapshot in time. There are longer monitors such as a Zio patch or a Holter monitor that can be worn for up to 2 weeks. And then sometimes even that period isn't long enough to monitor. And so we can place a very small device just under the skin, under the chest, in an outpatient day procedure setting under local anesthesia. That's called an implantable loop recorder. And it's a very tiny, almost smaller than a AAA battery, that records, and it can be left in for years, in fact, to monitor the ongoing rhythm. And in some patients who have such rare episodes, that may be the only way to detect it to ensure that it's no longer occurring.
All right. I have someone asking for a comment on AFib with RVR.
So AFib, or atrial fibrillation with RVR, is just atrial fibrillation with what's called a rapid ventricular rate. So not all atrial fibrillation is fast. Sometimes patients may have the abnormal irregular rhythm, but the rate at which that rhythm is occurring is still within normal limits. AFib with RVR refers to atrial fibrillation where the corresponding rate at which the ventricles or the bottom chambers of the heart are squeezing is very rapid. So that's a fast, irregular heart rate. Generally speaking, patients who have AFib with RVR tend to have more symptoms and may develop low blood pressure and experience more dizziness, lightheadedness, or pass out.
All right. I think you went through this, but during the presentation, but will the LAAC stop AFib or just help prevent the clot risk?
It's important to note that the left atrial appendage closure will not address the underlying rhythm. It is simply to prevent the stroke risk and minimize bleeding risk. It's the medications, the cardioversions, and the ablations that are going to stop or mitigate the atrial fibrillation.
Great. Do you have any statistics about AFib patients who are taking blood thinning medications getting stroke?
Yes, it's variable and it depends on a number of factors, including the patient's age, gender, and the presence of other health conditions. So there are calculators out there which you can actually access on the web where you can plug in your various differences, whether it's your age and the presence of those other medical issues like high blood pressure, and determine what your averaged annual stroke risk is with or without blood thinners. All
right. And I have a question about how can a spouse help their partner who has AFib? It's an interesting question.
So I think there's a number of ways. First and foremost, if you suspect AFib, taking your spouse or partner to be assessed by a health professional to confirm the diagnosis. If you have a partner that already has atrial fibrillation, then it's important to make sure that the issues we brought up tonight have been addressed. Has someone spoken to them about what are we doing about managing your stroke risk? Are you on blood thinners? Or if not, have we considered this left atrial appendage closure device? In terms of managing the atrial fibrillation, are they on medications to either control the rate of the atrial fibrillation, how fast it's going, or the rhythm itself, or both? Has a cardioversion been considered? Why or why not? And then finally, are they an appropriate candidate to potentially have an ablation? So it's important that all of these questions are asked and answered by your healthcare provider. And if they're unable to answer those questions, then a referral to a specialist such as myself or my colleagues like Dr. Perino, who I mentioned, who is an electrophysiologist and specializes in abnormal rhythms, including atrial fibrillation.
All right. There was a question that I can answer about can the Zoom presentation be reviewed as a replay? And yes, it will be on our website and on the Stanford Health Library YouTube channel in a couple of weeks, let's just say, but it will definitely be available to see again. And we've gone through I got a new question coming in. I'm sorry. Many questions. Oh, someone's wondering about the URL of that site that you just mentioned that can determine the risk of stroke.
Sure, I can. What I'll do is I'll pull that up and put it into the chat box.
Okay, great. Is that the last one? Yeah, let's see. Well, I want to thank you, Dr. Sharma. This was fascinating. I learned a lot. Also, I want to thank our audience for joining us and for the great questions. If you'd like additional information or resources, just please contact the Stanford Health Library. And we hope you'll join us for our next lecture. Thank you very much, Doctor.
My pleasure. Thanks, everybody. Take care.
Bye-bye.